Pneumonia and Diets, Protecting Your License from the Big Three. And our speaker today is Ed Bice, and I will tell you a little bit about Ed. Thank you for being with us today. Ed is a clinical consultant for IOP Medical, and he works clinically at a nonprofit speech and hearing clinic. He has experience in various settings, including acute care, outpatient, home health, and skilled nursing. Ed has held various leadership positions, including a regional manager, vice president of clinical services, and chief operating officer. Ed has been a guest on national and international dysphagia podcasts and has published numerous articles in peer-reviewed journals. He was an invited committee member to develop the ASHA Adult Dysphagia Practice Portal, which provides clinicians with guidance concerning assessment and treatment of swallowing disorders. And Ed is the co-author of Adult Dysphagia, Clinical Reasoning and Decision-Making Guide. He teaches an introductory and advanced swallowing course at the University of Maryland as adjunct faculty, and he has served as an expert witness in court cases related to swallowing and swallowing disorders, and has been an invited speaker for universities, state, national, and international conventions on various topics in dysphagia. So Ed has quite a resume, and I made sure to read all of it. And I have to tell you, Ed, before the first time I met you, someone said to me, "Watch out for Ed Bice." And I said, "Well, why?" And they were like, "Well, he really knows his stuff." So I said, I hope that I learned something, and I definitely did. We really appreciate you being here today, and I'm gonna let you take it away. I just want to let everybody know, if you please hold your questions till the end. We'll do a Q&A session, and then we'll wrap up. Thank you.
Well, thank you so much for that glowing introduction. I really appreciate it. I'm a little bit tired just from hearing it. So, nope, it didn't do it. There we go. So today we're going to talk about aspiration, pneumonia, and diets, and the best way to protect your license from those big three. These are my financial disclosures, as most of them have already been stated. And if you can't hear the sound, let me know. Okay, great. So here's a typical response on social media. I have a patient who aspirates on thin liquid. They refuse to drink thickened liquids and sneak thin liquids from other trays. Nursing will not monitor them. Am I going to be responsible when they get pneumonia? Should I continue to treat them, or should they be discharged for noncompliance? And then a typical response. Have a meeting with the family and tell them what the patient is doing and that they're going to get pneumonia and probably die. Maybe they can get the patient to stop sneaking liquids. At least they will know you tried. Or maybe you should allow the patient to drink what they want, educate them about the risk of pneumonia, and document, document, document. Some people are just never going to listen to us. I can't let the patient drink thin liquids. I have to protect my license. So those are the things that we'll be discussing and reviewing during this webinar. And here is the agenda. We're going to talk about aspiration pneumonia and try to connect the dots between those two things. We're going to face the facts about diet and liquid modifications, and then we're going to talk about how our license play into all of this. So I always like to start out by talking just briefly about that I've most likely worked in your setting, because probably the most often comment that I receive from my talks is, yeah, but he doesn't understand because I work in, and they'll say their setting. I probably worked in your setting, and I understand that there are administrative constraints in your setting. And I also understand that there's nuance. So when we talk in a webinar like this, or even in a course, it's very difficult to layer all the nuances of every situation and every location where we work and every situation we encounter. So I get that, but when I talk, I'm really talking more in general terms than I am in specific terms. So let's start by talking about aspiration pneumonia and trying to connect the dots between those two things. So we have some really good research, and we know this research, but I like to reiterate it because sometimes we have head knowledge, but it's not reflected in our behaviors. So this study from 1998 that probably all of you know, by Dr. Susan Langmore, concluded that documented aspiration of food or liquid on an instrumental swallow study were not statistically significant predictors of pneumonia. So every day, if you work in acute care or if you work with patients with dysphagia, you're the recipient of swallow studies, or you're doing swallow studies if you work in acute care, and you see people aspirate on these studies. And even though we have known this since 1998, now prior to 1998, when I practiced, we really did think that aspiration would always lead to pneumonia and that aspiration was the predictor of pneumonia. But this study in 1998 taught us otherwise. And that's been a few days. And so the lesson to us and the reminder today is that when we see aspiration on imaging or when we read about aspiration in a report, that does not necessarily mean that this person is going to have any kind of issue. Then, if we fast forward to 2017, the study by Bach et al. Concluded that dietary modification recommendation had no impact on the time to first pulmonary event or mortality over a 54-month follow-up. So in this study, they were looking at acute care patients who had imaging during their acute care stay. They had a PAS of 5 or greater, and many of them were recommended diet modifications and went to post-acute care placements where that diet modification was followed, and they were looking to see if the people who had no diet modification or who didn't follow the diet modification had any different outcome for first pulmonary event, respiratory event, returning to the hospital, or death over 54 months. So a long time. And it didn't. There was no connection. And then this early study that's probably one of my favorites because of how they followed the patients and the information that they give in the study said, our results indicate that liquid perennial aspiration should not be assumed to directly affect pneumonia frequency in elderly nursing home residents. So I love this because these nursing home residents are the most frail and sick individuals that among our population. And even in that population, they found, and they followed these folks for 3 years, they found that there was no direct connection between aspiration on imaging and the development of pneumonia. And he went on, Feinberg went on to say, it's unclear what volume of aspirate or what frequency of aspiration is required to cause pneumonia, regardless of etiology. And I think these three studies are pretty representative of our whole body of literature. And I just continue to encourage people. I'm not saying be cavalier about aspiration and pretend that there is no issue when someone aspirates. But what I'm suggesting is that we go beyond our head knowledge, that aspiration is not the end all be all, and that we actually put it into action, what we know. The other issue that we have as speech language pathologists is that we are handed off patients and we're told by someone that this person has aspiration pneumonia, or we read it on a chest x-ray, this person has aspiration pneumonia, or it's in some note somewhere from a physician. But we need to understand that aspiration pneumonia is a vague diagnosis that can be the result of many things. Just a pulmonary infection that has nothing to do with food or liquid, from GI reflux, and then also from pharyngeal aspiration. And I think that this statement right here from this article by Ferguson and others is something that we need to remember. There are at least 13 syndromes, sometimes labeled as aspiration pneumonia, including community acquired pneumonia, hospital associated pneumonia, ventilator associated pneumonia, and pneumonitis. Aspiration pneumonia is not a one thing. There isn't just one definition. And among us and our colleagues, when we say aspiration pneumonia, we have a very specific idea of what we're talking about. Someone drinks or eats something, it goes below the vocal folds into the lungs, and it causes some kind of reaction in the lungs, and the person ends up with pneumonia. That's what we think when we hear the term aspiration pneumonia. But I want everyone to understand that when the radiologist writes aspiration pneumonia on the chest x-ray, or when the pulmonologist writes aspiration pneumonia in their note, it may not be related to food and liquid at all. And I talked about already the idea of reading this on a chest x-ray. My patient has aspiration pneumonia. We have to understand that a chest x-ray has a sensitivity of 69% and a specificity of 77.8% to diagnose any kind of pneumonia. And obtaining a differential diagnosis, is whether the pneumonia is a aspiration pneumonia or whether the pneumonia is caused from some other reason, is not possible to achieve on a chest x-ray. Just know that. Approximately 65% of people diagnosed with aspiration pneumonia are diagnosed based on chest x-ray alone. Um, Someone says, "Oh no, this is going to trigger me." It triggers me every day. So I'm glad. So now we're in the same camp. And then we have to understand that there's no gold standard test for the diagnosis of what we call aspiration pneumonia. Okay? So here we are chasing all of these rabbits down holes that don't end up where we think they end. Chest x-rays have poor sensitivity and specificity. Most aspiration pneumonia is based on the diagnosis found on a chest x-ray. And there's no gold standard for the diagnosis of what we call aspiration pneumonia. And just as a review, when we talk about sensitivity and specificity, um, yeah, and CTs are better. So someone said in the chat, we see a lot of chest x-rays indicating, and only CT shows chest pneumonia. CTs are a much better option for sure, but they're still not perfect. Their sensitivity and specificity elevate with, but that's still not perfect. Okay, so sensitivity is true positives, meaning the patient has pneumonia and the tests are positive, and specificity is true negative, meaning the patient does not have pneumonia and the tests are negative. I just wanted to review sensitivity and specificity because I know that sometimes those things get muddled in our head. So then, when reading a chest x-ray, what are some traditional indications that the pneumonia may be related to pharyngeal aspiration? Well, I don't know about you, but when I was growing up as a speech pathologist right after the dinosaurs died, we were always told to look at the right lower lobe because that's where the major bronchi goes, and it would indicate that aspiration would be gravity dependent because something that's heavy, right, should fall down into the bottom of the lung. So right lower lobe was kind of, where they told us that the patient has right lower lobe pneumonia, that's aspiration pneumonia. Well, unfortunately, we have more updated information, and even this information is quite old now, that they looked at a pa they looked at a group of patients with fluoroscopically documented perennial aspiration. So they had a modified barium swallow study and they aspirated. And in that group, 15% of the people did present as with lower lobe pneumonia, but 68 presented with bronchial pneumonia. So in this study, the majority of the people presented with bronchial pneumonia, not right lower lobe pneumonia. Yeah, so it is not a definite indication. There are lots of reasons why someone may have pneumonia in the right lower lobe. So here is just a graphic of what right lower lobe pneumonia looks like. Remember, good air exchange is black. So when the lungs are black, that means that there's good air exchange. But down here, you see that the right lobe down here has some white where this left doesn't. And then here, this is what bronchial pneumonia looks like. It's more diffuse, it's more spread all over um, it's spread all over the whole lungs. And someone said, is it a gravity dependent zone that is a possible indicator? So what I would say, um, we don't know. I spent 6 months of my life trying to figure out how aspiration pneumonia develops and wrote a blog in Dysphagia Cafe about it. If you haven't read it, you can go there and read it and learn of my journey, my 6 month journey, trying to figure out aspiration pneumonia. And I would say that if something is really heavy, and the patient isn't very active, that the patient is wheelchair or bed bound, or they have a pulmonary disease where the mucociliary clearance is not very functional, that you may find the pneumonia down there in the bottom right side. But I'm going to say probably for the majority of, like, I work with a lot of head and neck cancer, and because I work outpatient, so my people are walking in the door, that I'm probably not going to see that in my patients very often. Right. And there are many people who eat in what we call an abnormal position, and maybe we'll talk about that. So here's my conjecture about why we see bronchial pneumonia more than right lower lobe pneumonia. So I'll go back. So if you think about, our patients aren't generally aspirating a gallon of milk. They're generally aspirating small amounts. And as it travels down the trachea, the bronchial tubes, it's getting smaller and smaller, becoming more and more diffuse. And then when we breathe, it's like turning on a fan. And so that liquid just gets blown all over the place. And this would be more indicative of bronchial pneumonia than a right lower lobe pneumonia. And so that's my conjecture. I have not read that in the literature, but as I read through the literature and tried to figure out how this could happen and how this might be possible, that's what I had in my head, and that's how I could conceive this in my head. Again, if you aspirate a hot dog, that's not going to happen. But most of our patients are aspirating thin liquids and they're small amounts, and so it just kind of gets blown everywhere. So there's just a graphic representation of what happens in my conjecture. Again, if you aspirate a whole gallon of milk or a hot dog or something like that, the situation will probably be different. But in normal circumstances, I would say don't just look for right lower lobe pneumonia. And if it's just chest x-ray, probably just disregard it. Another issue that we have in our literature is when we study people who are typically sick, like nursing home patients, et cetera, The issue is that the dysphagia literature counts all the pneumonias that occur during the study period. So if you look even at the Langmore 1998 study, which is amazing during the time that it was written and was, it continues to be a seminal work and is just an amazing article, that their criteria for diagnosing with someone with aspiration pneumonia was primarily the chest X-ray. So we just went through how chest X-rays don't have the specificity and sensitivity that we need to diagnose aspiration pneumonia. So even that article, that was their major criteria. That was where they put the most emphasis. So someone commented, I find a lot of people will read the term infiltrates on a chest X-ray and assume that it's aspiration. Yeah, infiltrates are, again, from lots of reasons. And, my conjecture, my recommendation is we need to stop looking for problems. We really do. Um, so because we count all pneumonias, it inflates the actual incidence of aspiration pneumonia in our studies. So when we think about the fact that 38% of people in the Langmore 1998 study um, had pneumonia, we have to consider that that 38% is probably significantly inflated from the people whose pneumonia was actually caused by pharyngeal aspiration. Okay, so I have another comment. If we stop looking for possible, our caseload would get much smaller. Well, maybe if we actually rehabilitated the people who need our help, we would be able to keep them on caseload a little bit longer. And I hear what you're saying, but ethically, do we make decisions on how big our caseloads are or on what's really wrong with our patients? And that's the question you have to answer for yourself. There is no gold standard for diagnosis of aspiration. We have no gold standard. And so we have to put the pieces of the puzzle together ourselves. Um, we have to use more than a chest x-ray and more than aspiration. We have to look at those things that correlate to aspiration pneumonia. We have to look at their medical diagnosis and patient factors that would indicate to us that, that there is more to this puzzle than what we're seeing. These are great questions, and I appreciate your input. Um, if we overtreat and overdiagnosis, oh yes, we're definitely impacting patients' quality of life by overmodifying diets. Um, yeah, bronchoscopy is one way. If you do a bronchoscopy and you're pulling food out of someone's lungs, that would probably be an indication that it's a problem. And we also harm our credibility by overdiagnosing. And yes, we're going to talk about that in just a minute. The next comment. So it's important to understand that aspiration is a common event that can be within the normal spectrum of physiology. And the most common consequence of aspiration is to have no consequence at all. Whatever you aspirated is cleared, and the host, the parenchymal host, which is the alveoli, yeah, down in the lungs, are actually not impacted by it at all. Parenchyma is the actual part of the organ that does the work. So the very part where oxygen exchanges. But this is by a pulmonologist. DiBardino is a pulmonologist, and the most common consequence of aspiration is to have no consequence at all. So that means when we see this, we need to stop doing this. And particularly, I encourage you, I'll show the video again, not to have this response because this is my swallow. And I don't want you coming into my life and telling me I need to do something different than what I'm already doing. Okay. Hang on one second. I got a long one. If my sniff facility It is less aspiration pneumonia and more frequently choking episodes, which are very upsetting. Yes, choking is a whole different conversation. Whole different conversation. Yep. So the conclusion is that the development of about this section on pneumonia is the development of pneumonia is not linear. Aspiration does not equal pneumonia, does not equal death, and that the development of aspiration depends on multiple factors that often defy explanation. So if you start trying to figure out how people get pneumonia, your computer is going to catch on fire. I promise you. It's wrong to assume, is it wrong to assume visualized aspiration of thin liquids on MBS is aspiration that will continue? We don't know. And so I guess it's philosophical. If you're seeing something on a modified Barron swallow study or fees, certainly I wouldn't think that it was ongoing if I only saw it one time. And I would never stop doing what I'm doing because I saw it one time. If I see it happen 3 of 5 times, then I might say it's a pattern, and start making more assumptions. But I would never do it based on seeing something happen one time. Okay. Um, so we'll have to talk offline about choking episodes. That's a different conversation. Um, Yeah, we're going to talk about all the predictors of aspiration. If a patient has high blood pressure and does not want to take medications, right, then nobody makes them take the medications, right? So why do we think that what we're doing is any different than that? Yep, I agree 100%. So we have the pillars of aspiration pneumonia, which are Dr. John Ashford's idea, and they're amazing. And he spent a lot of time, and that's really his area of expertise. My brain doesn't quite think like his brain. And so, based on the research that I've read, my way that I think about the development of aspiration pneumonia is a little bit more complex and has a little bit more thought process. I ponder things much more deeply, I should say. And so this is my web of the development of aspiration pneumonia. Um, yep, yep. So I'm not going to get onto choking tonight. Okay, we're going to talk about informed decision making in just a minute. You all are getting ahead of me. So let's talk about diets. So these are the top 5 interventions according to, oh, thank you. According to research. Notice that none of these 5 things change the way the physiology of the swallow. I want you to notice that. These are putting band-aids. These are not telling us that speech pathologists are necessary because a technician can say they aspirated on thin, so let's give them, something that's thickened. Look, if they turn their head this way, they don't aspirate anymore. All of these things could be done by someone who is not a pathologist. So my question is, why do these continue to be the most common interventions? And what do we really know about altering diets and liquids? Okay. Yes, I agree. The goal should be to be restoring their swallow function. We are therapists, and so we're trying to help people get better, not just put band-aids on situations, hopefully. Um, so this article that's been, again, this is not a new article. Clinical trial data to establish best practices with respect to reducing aspiration pneumonia in the elderly are limited. There is no strong evidence supporting the use of thickened liquids as an intervention for patients with dysphagia. And this is a systematic review here, and they've recently updated this systematic review, but excuse me, they didn't update their findings. No evidence was found for two important outcomes, mealtime performance and quality of life, with regard to risk of pneumonia, death, aspiration, dehydration, weight loss, and intervention adherence. There were no significant differences be found between those people whose diets were altered and those people whose diets were not altered. Notice pneumonia, death, dehydration. Okay. So we're not helping people, is what by changing their diets, is what that is saying. Okay. Um, yes, I think it is being recorded, but and Jenny can tell you at the end whether or not this will be available for other people to review. I bet you have someone in mind you want to hear this. Um, so Sean O'Keefe, who is a physician in the UK, is one of my favorite people on the earth. I've never met him personally, but his work is just so amazing. And he said this in this 2018 article: the disconnect between the limited evidence base and the widespread use of modified diets suggests the need for more careful consideration as to when modified diets might be recommended, not taken, but even recommended. To patients or their representatives have a choice whether or not to accept modified diets and must receive adequate information about the potential risks and impact on quality of life, as well as the possible benefits to make that choice. And there's an urgent need for better quality evidence, obviously. We know that. So he's suggesting that we need to be pathologists, right? Not technicians. Pathologists use all the information and synthesize the information to come up with a plan. We don't just say, aspiration, do something. And what he's saying is that even before we recommend diets, that we need to have more careful consideration. Because if we look at the evidence, what we find is that there isn't anything to support the evidence. There's nothing in the evidence to support using diet modifications um, as a frontline intervention. Um, why does Medicare pay skilled nursing facilities? That's a great question. And I had a whole conversation with the folks at ASHA when that was being hashed out. And it's because diets cost more, not because, and then facilities take that as an incentive. So yeah, it's a problem. I've been a speech pathologist for greater than 25 years, and treatment of dysphagia has changed a lot. However, I'm finding that some therapists with less experience take all these recommendations. Yep, I've been doing it for over 40. So a lot has changed in my career as well. In the beginning, I walked around with a pocket full of laryngeal mirrors and a cup of ice, and I thought I was saving the world by poking everyone in the back of the throat with a stick, because that's what Dr. Logeman taught me to do. And then everybody wagged their tongue as well. That is not what I do anymore. And yeah. And hopefully everyone has abandoned those things. Hopefully everyone has abandoned those things. I can't say that it's true, but hopefully. So let's take a few minutes and consider the possible impact of diet changes. So remember, Dr. O'Keefe said that we need to consider diet recommendations before we make them to the patient. And I love all your comments. So, I keep looking because they're so fun to read. So yeah, we got lots of people here with lots of experience, and that's great. And hopefully that we're not saying, well, I've been doing this for 30 years and this is what I know. Well, no, it doesn't matter how long we've been practicing. It matters what we learned during those years of practice. And so, yeah, we're going to talk about those right now. So this is a study from 2018 that said that people on honey thick and nectar thick liquids had lab values signifying dehydration. With thin liquids, patients reported significant improvement in their satisfaction related to their thirst. Can you imagine always being thirsty? I mean, I just can't imagine 24 hours a day, 7 days a week, always feeling thirsty. It's a horrible thing to do to someone. We also know that prescription of minced or pureed foods was significantly associated with the risk of malnutrition among residents living in nursing homes, even while adjusting for other covariates. Um, so this study actually looked at lots of other issues besides just their diet. And just another aside, last year at the Dysphagia Research Society, and these are things that we don't know and we make a lot of assumptions about. That that there was a study that was presented at DRS that I haven't seen published yet, that minced and moist, whatever level IDSI that is, actually caused more residue than pureed or regular textures. And so we have all of these levels and all of these really neat packages and talk about how we all talk about it the same way. The problem is we don't know what it's doing to the person that's sitting in front of us. So it doesn't matter if we have all these neat categories and have all these great ways to talk about it. What really matters is what's happening to the person sitting in front of us. And we're still just scratching the surface about those things. Yes, it is hard to change MD's ways of thinking about aspiration. We have worked for 50 years helping them think that aspiration is the end all be all. And if they don't do something about it, the patient's going to die. And so we're going to spend the next 50 years unteaching them that. And that's on us. We did it. We are the reason why we're here, and we're the reason we're going to have to be the reason how to dig out of this hole. Backfill. We're going to have to start backfilling. So this study told us that texture modification was independently associated, again, with poor nutritional status and prolonged length of stay after adjusting for other co-founders. And if we look at the nutritional value of food, we will understand why that is occurring. So often we think that when we go from a regular diet to a pureed diet, that that's just a lateral move. So in this study, they just pulled a regular tray, a mechanically altered tray, a pureed tray, and a liquid tray off of a line at a hospital. And they just analyzed it. There's no people involved in this study. They just analyzed it for, what nutritionists look for, energy, and I just pulled out three: energy or calories, proteins, and lipids. And you can see that in a mechanically altered diet, there's 11% or almost 12% less calories. In a pureed diet, it's almost 31% less calories, and in a liquid diet, it's 40%. But then when we start talking about sick people and what people need to heal, if you have a wound or if you've had an acute insult, protein is the building block of the cells. And this is how we get back to wellness, by the cells, becoming healthy and creating health. And we see here how the protein diminishes as we get farther away from a regular diet. And you see how the lipid or fat content diminishes the farther away that we get from a regular diet. So we're worried about people losing weight. And so we put them on a pureed diet, and now there's 41% less lipids and 45% less protein and 31% less calories. So the question becomes, how much of a pureed diet do you have to eat to equal half of a regular diet? Well, it looks like you would have to eat 150% of a pureed diet to equal a regular diet, and you would only have to eat 50% of a regular diet to eat 100% of a pureed diet. So, we're playing all these shell games with things that we don't really understand, right? Um, I'm working on an IRB right now for a study about how saliva changes with radiation. And I've spent the last month of my life reading about saliva. and all the immunoproperties of saliva and what happens when people have xerostomia and the proteins and the buffer. So you know that the buffer effect of saliva neutralizes the pH, and that's why we can eat really spicy foods and really acidic drink things like wine because the saliva content buffers and changes the pH of whatever we put into our mouth so that it's neutral. And so, I think about all these people with xerostomia and how they have health issues, and it's because, you know, their system is being inundated by things that aren't being buffered, and that the immunoproperties of that are supposed to be in saliva are not present. And so, and I say all that to say, the more that you learn, the more that you know that the things that we're messing around with are not things we should be messing around with because we don't understand the system well enough to be making decisions and making recommendations because we just don't understand the system. And like I said, the more that I know, the more that I am reticent to do anything except, rehabilitative interventions to try to help people get better. Because I don't understand enough to be making recommendations to people. Yeah. So let's talk about thickened liquids. So these are the most common, or the most, yeah, if you read lots of articles, these are the most common complications that may arise from thickened liquids. Slow gastric emptying. So all of our patients already have constipation, right? We know that. I mean, they're all on all these kinds of things to help them go to the bathroom, and then we put them on thickened liquids, and we slow down their gastric emptying. And the other problem that when we slow down their gastric emptying is they feel full, and so they don't want to eat. And so it's this vicious cycle of they're losing weight, and so we put them on a pureed diet and thickened liquids because they're also aspirating, and now their their gut is slowing down, and so they don't feel as hungry and they're eating less. And it's like, are we helping? That's the question we have to ask ourselves. And then we also increase the risk of reflux, which is another great source of pneumonia and bacteria in the GI tract and in the respiratory tract. And then I already said, maybe why there's a reduced appetite. Hypotension falls. Hypotension is, of course, an outgrowth of dehydration. Falls because of dehydration leads to weakness, confusion, falls. I already mentioned constipation, increased pharyngeal residue, which is, something we're trying to get rid of, and that we think that we have to save the world from increased pharyngeal residue, and so then we just create it. Urinary tract infections are a common side effect of thickened liquids, confusion, delirium, and this one, poor recovery from illness. Wow. If we told our patients, people who drink thickened liquids have poor recovery from illness, how much cooperation are we going to get with patients consuming thickened liquids? And then we have interference with the way that medications dissolve and are metabolized in our system. There are others as well. It can interfere with glucose levels, which is a real issue for a lot of our patients as well. And then another side effect of thickened liquids is pneumonia. So then, many patients with dysphagia don't follow our recommendations to choose thickened to consume thickened liquids. Outpatient, my patients continually ask me, should I continue to drink this? That the therapist at the hospital told me when I worked in acute care before I came to outpatient, I did a weekend rotation in acute care, and I would see patients who were like on their second or third or even fifth stroke, and they tell me, the previous therapist told them they had to drink thickened liquids, and they would want to know what I thought about it, and you're going to learn what I think about it. But so in this study that I think is really interesting, the risk of aspiration was explained to non-dysphagic patients, and they were allowed to sample two fluid consistencies, nectar thick and thin. And participants suggested that long-term use of thickened fluids would significantly impair their quality of life, which we would all agree. Um, And what's so interesting is subject assigned to ITSE level 2, which would be nectar thick liquids, said that they were willing to sacrifice half of a 10-year lifespan to avoid consuming those liquids, but continue to drinking thin liquids. And so I think we would all agree with these people. And so if we agree with them, then why don't we treat our patients with that same respect? That's my question. So, the standard of care. Let's talk about this standard of care and get through with this, and then we'll get to all those wonderful things that you're saying in the chat. So, the ASHA Code of Ethics reflects the professional values and expectations for science and clinical practice. This is what their preamble says. And that the Code of Ethics is a framework and guide for professionals on day-to-day decision making in our professional conduct. So, if you go to court, that's the yardstick you'll be judged by. The Code of Ethics says it's obligatory and aspirational. So it should be used. We all should know these Code of Ethics because again, in most states, it's how we will be judged. Okay? Because ASHA Code of Ethics says it's the standard of care. And unless your state establishes some other document as the standard of care, it will default to the national standard of care, which is the ASHA Code of Ethics. And not to follow the standard of care is considered to be negligence, medical negligence, and that can have significant consequences for us. So I point out that our standard of care says individuals shall obtain informed consent from the persons they serve about the nature and possible risks and effects of services provided, technology employed, and products dispensed. And it says if there's diminished decision making, the ability of the person served is suspected that they can't. I'm sorry, I'm having a hard time now because I'm watching all those numbers go up in the chat. If diminished decision-making ability of person served is suspected, individuals should seek appropriate authorization of services, such as authorization from a legally authorized or appointed representative. So it tells us what to do. We don't have to guess. We don't have to say, well, what if my patient isn't cognitively I'm sorry, isn't cognitively able to make these decisions? Well, the Code of Ethics tells us what we have to do in that case. Okay? So we don't have to wonder and we don't have to ask that question. Now, here are the components of informed consent. Nature, we have to explain the nature of the issue. We have to talk about the potential consequences of that issue. We have to provide alternatives to the person. We have to measure understanding and accept the voluntary choice. This is informed consent. Notice nowhere on here does it say we have to make a recommendation. Okay, so I added this slide today. So if you got the slides before today, you didn't get this because I just spoke for a whole day at a hospital in Kansas City, and they wanted something about documentation. So since I had this documented, and I've color coded it to the components of informed consent. But I want to get to questions. So if you didn't get this, you can either email Jenny or you can email me, and I will be happy to send this to you. But this is an example of how I would document a discussion related to informed consent. Okay, and actually, I have this on a Word document so that I can just modify it from based on each patient and then copy and paste it into my EMR. So that's how I handle it because I know this is a lot of documenting. And I also have a sheet that I give my patients that has all the possible positive and negative consequences of different choices. So I don't reinvent that every time I have the discussion. So I always use this slide when I speak. So if you've ever heard me speak before, you have seen this slide. And I know there's lots of questions, so I'm trying to rush through this so we can get to all those questions. Because this is something I like to talk about and I love to engage with everyone about the things they want to hear and they want to know. So our patients don't fail rehabilitation. The problem is we fail to know what our patients actually need. And I hope that this is a quote of Dr. Maggie Lee Huckabee's, and this is what motivates me every day to get up and learn more. Because if my patient isn't succeeding, it's not that they've met their max potential, it's that I've met my max potential. And so I need to do more and do better. So let's get to questions. And Jenny, are you going to moderate the chat? How are you going to do it?
Hi, Ed. Yes, thank you so much. That was amazing. And everybody in the chat is very engaged and active, and I love seeing that. And thank you for taking questions as we went along. So just the housekeeping stuff. If you want to email me the slides and if you want to share them or that the last informed consent paper, then everybody can email me and I can
Okay.
share them to save you the trouble. I will type my email into the chat and you can reach me there. Um,
And I will send her this updated PowerPoint before I get out of this seat this evening. Okay.
Perfect. And it was amazing, Ed. Yeah, thank you.
Well, thank you.
Okay, so we have quite a few questions. I'm gonna go back. I don't want to miss any, but we'll if anything catches your eye, Ed, feel free to
Okay.
let me know. Um,
I'm going to open it up.
let's see. So we talked about the slides, and then I think you answered this. This is, do you suggest don't modify either liquid or texture modifications despite clearly showing frequent suspected penetration and signs of aspiration, also getting worsening chest conditions and pulmonary events?
So okay. So here's what the ASHA Code of Ethics in federal law says. We get informed consent. So I would never document or say verbally, and I have a I have a whole presentation on semantics and how important the words we use are. I don't say that I put someone on something because what that says is I'm disregarding their autonomy. Whether I did or not, if I say it, that's what I'm saying, right? I did it. I don't do anything to people. They make decisions about what happens to them, right? And so, um, if that person believes that that's what's best for them, say they cough all the time when they drink thin liquids, and that's very uncomfortable for them, and that makes them uncomfortable, or it makes the people around them uncomfortable, and that they don't want to do that, then by all means, please thicken your liquids. By all means, if that is what makes your life better.
Yeah. And I think
So we don't use the word never. We use in circumstances where patients believe or that it helps them, then yes, by all means use it.
yeah,
But not when I think it helps and they don't.
exactly. And I think that goes back to treating everyone as a person with dignity and compassion. That's what our patients want to feel when they're working with
Right.
us, I'm
And
sure.
that's what we want to feel, right? When we're
Yeah,
patients, that's
yeah,
what we want to feel.
absolutely.
Um, okay. Yeah, that's a good question.
Okay, go
Okay.
ahead.
That question that came up, what when the patient asks, what would you do? And that often comes up. And
Mhm.
so I say, wow, you have a different medical circumstance than me, and you live a different life than me. I don't live your experience. And so I really can't make that decision for you. Dr. Leslie tells this great story. She talks about people's lives being in three segments, just like a movie, the introduction, the climax, and she says we just interact at one juncture. Like if you're thinking of a 3 hour movie, we may be there for a minute or 60 seconds of that 3 hour movie. And we need to realize our place in the movie and not think that we're the star, but realize we're probably not even getting credited we're not even going to get credit for appearing.
A hard lesson for some, huh?
Yeah.
Uh, okay, and we have what do you think is the value of instrumental evaluations, and when do you think they are most important, given that aspiration is not necessarily predictive of pneumonia and diet modifications may not be effective?
Yeah. The purpose of imaging is to develop a treatment plan, not to find aspiration, not to find residue or whatever we're looking for. That we are looking to develop a treatment plan. So if the patient isn't interested in treatment, then we don't need imaging. If the patient wants treatment, then we go to imaging. So we know what is the pathophysiology um, so we know what treatment to provide. And that's not, you know, there's nothing on imaging that tells us what diet someone needs. You know, I, there's nothing, and I've asked this question again and again when I present. So if the patient has a 10 millisecond delay in time to laryngeal vestibule closure and a 15 millisecond shortened duration of UES opening, what diet should they be on? We don't know.
Right.
All we're trying to do is going around stomping out aspiration. And it's like, we don't even know what that means. And so let's shift our brains.
Yes.
Okay.
Yeah. And I'm so glad that you're doing this talk. It's a start, right? Raising the awareness. Okay, let's see. Somebody asked about free water protocol. Do you ever incorporate?
Yeah. Certainly, I think that again, if that's what the patient feels comfortable, I think that that's certainly an option. But, in the last month, studying all this stuff about saliva, my question now is because the rationale for a water protocol is that it's pH neutral. Well, we know that the water that we drink has all kinds of stuff in it, right? That it has fluoride in it and many other things in it, that it's not neutral. And so if the buffer in our saliva is making everything we put in our mouth neutral, and I don't know the answer to that question, then what does any liquid matter?
Yeah. Well, that
You
is a
know,
good
so
question.
there's a question that I hope someone will research. Um,
A subtle hint to everyone.
yeah.
Okay, so we have, how does this information apply to pediatric populations? I saw a lot of the research was around our geriatrics, but can show some of these decision making with, but can some of these decision makings with how we view aspiration be applied to our younger population too?
Yeah, so it's a whole different ballgame. This presentation was about adults. We know that like adding thickener to tube feeding in individuals, there's a paper out like within the last 2 years can actually diminish reflux in those babies. We also know that their lungs are developing and that aspiration could potentially have more of an impact on babies than adults. We also know that aspiration of chest milk, which is the new term, um, is um, is less likely to lead to problems than aspiration of formula. So there's a whole lot around infants. It could be a whole nother talk.
A lot of
And
other
it's not my
factors.
area of expertise. It's not my area of expertise. I know some of, but I know enough to be dangerous. Um,
Well, that's enough then. Okay, so then let's see. For people with degenerative disease like dementia, sometimes the complementary strategies are the only way to reduce the aspiration. However, the research showed the thickened liquid has no significant change. What can we do to help this group?
yeah, I think that so the other thing about that I find so interesting because actually I have a study that we just resubmitted today with revision looking at how the diagnosis of dementia influences clinical decision making in speech pathology. We gave two cases in a survey, one with dementia and one without dementia. Same problems in the swallow, and to see what the recommendations would be. And I found it very interesting that so many SOPs recommended compensatory strategies, and it's like compensatory strategies require memory, right? You got to remember to do them. And if you think that this patient is cognitively impaired enough that you wouldn't do treatment with them, why would you give them a compensatory strategy? Anyway, that's a whole side. So I think that the best that we can do is educate. If I would say if a person can follow a one-step command, that I have the potential to help them with some rehabilitation. They have to follow the one-step command. But I use a lot of biofeedback,
Mm.
and so that they're getting a lot of visual information, including things like EMST, which provides feedback, right? When you bust the spring, or not bust it, when you
They get
release the
that
spring,
whoosh.
it makes, well, yeah, you hear the sound. It's
Yeah.
feedback, right?
Mhm.
And so I think that, and we know from research that when you can provide biofeedback, that it reduces the cognitive load of the activity. And so, for these kind of people, I actually published a case study of working with a GDS level 6 patient that we actually did treatment with. And she went from being holding food in her mouth, not swallowing anything, to eating a regular diet in 2 weeks.
That's amazing.
And so, And it was basically through food chaining and techniques that typically use with kids. Um, but I think that there are things that we can do with these people, but it really is dependent on the individual. So it's hard to make this blanket statement, this is what I would do. But I try to be pretty creative and I don't give up on people really easily.
I think that's a great way to be. I think it is just about time to wrap up, but before we do, Ed, can you tell us a little bit about your book?
Oh yeah, thanks for asking. I don't have one right here. So it's through Plural Publishing, and it's adult dysphagia, and it's all about clinicians. So there's nothing academic in it. Actually, I told Jenny before, my wife, who's a teacher, I didn't know she was going to do this, picked it up and read it, and she came back to me and she said, I understood that. And so you don't even have to be a clinician to understand it, but it starts with screening and how we make screening decisions. And so you'll see, here's all these different screening tools. Um, and here's their sensitivity and specificity, and here's when you might use them, and here's what you would learn from using them. And then we go into assessments and how you can, and the tools that we currently have, the valid tools to analyze fluoro, to analyze fees, and what you're going to learn from the different tools and what you can do. And then we talk about treatments and what is the efficacy of different treatments and how we teach you how to determine appropriateness of treatments. And then we talk a little bit about dosage and we talk about the clinical process of, so now, here's how we go through this whole thing: assessment, analysis, treatment or intervention, assessment, analysis, and how it goes in a cycle. Um, so, yeah. So if you have the other thing I will say, I will put my email in the chat because we're
Perfect.
not
That was
getting
my
to,
next question.
yeah, if you, because there's lots of questions that
Yes.
we're not getting to. So if you have questions and you want to continue a dialogue with me, there is my email address where I can be reached. Um, ed@iopmedical.com. And I'm happy to engage with you. I hate talking about swallowing and I hate talking about helping people. Can't you tell from the way that, that like it's very painful for
Oddly
me?
enough, that doesn't come across. Uh, but we do appreciate your enthusiasm, and I appreciate that you're advocating for patients and for the right things in the field. So thank you very much for being here. Anybody who has any questions, you can reach out to Ed or to myself. We are so glad that you joined us today. This will be
Yes,
recorded and
I
available to
appreciate your time.
everybody.
I
Yes. Thank you
appreciate you
very
giving
much,
me your
everybody.
time.
Have a great evening, everyone.
ed@iopmedical.com. People are still asking. It's in the chat. Okay.
It's in
Ed
the chat,
at
and I'm Jenny at
iopmedical.com.
EMST 150, and you can email me also. Have a good evening, everyone.
All
Thank
right.
you.
Thanks.